Good morning, everyone. Good morning, ma'am. This morning, I'm going to discuss about thrombocytosis associated with myeloproliferative disorders. First, we will define first what is thrombocytosis and myeloproliferative disorders. Thrombocytosis, from the word thrombo, which is platelets, and cytosis is increase. So thrombocytosis, this is having a increased production of platelets. While myeloproliferative disorders, these are the blood cancers that caused by changes in the stem cells inside bone marrow, the tissue that makes blood cells. Primary or autonomous thrombocytosis is a typical finding in 4 chronic myeloproliferative disorders. These are the polycythemia vera, the chronic myelogenous leukemia, myelofibrosis with myeloid metaplasia, and essential thrombocytopenia. The first chronic myeloproliferative disorder is polycythemia vera. It's a disease in which there are too many red blood cells in the bone marrow and blood. So if we're having many red blood cells in the bone marrow and blood, it can cause blood to thicken. So magiging sticky yung blood natin. So if magiging too sticky yung blood natin, so di ba maraming mga conditions or mga complications yung mangyayari. The number of white blood cells and platelets may also increase. So, mataas yung production of white blood cells and platelets. The extra blood cells may collect in the spleen and cause it to become enlarged. They may also cause bleeding problems and it may clots form in blood vessels. The complications of polycythemia vera are these following. First, the splenomegaly, which is enlargement of spleen. Second is the blood clots. The third is the skin problems like reddening of the facial skin and full body itching or like mga rashes, ganun parang yung mga rashes sa skin natin. And other health problems due to increased number of blood cells. Polycythemia vera is diagnosed most frequently from a blood test examination, like in a CBC, complete blood count. So in a CBC, the result is you have a increased number of RBC, elevated din yung hematocrit natin and hemoglobin, and very low levels of erythropoietin. The treatment for polycythemia vera. There is no cure for polycythemia vera because it's a chronic condition. The treatment is only focused on the amount of blood cells, which will help reduce the risk of various complications. So, includes first is phlebotomy. So, phlebotomy is yun yung kukunin ka ng dugo. Usually, kukunan ka ng 300 to 500 ml of blood yung kailangan ma-remove natin every other day. Next is aspirin. This is recommended to reduce the risk of blood clot. Next is antihistamine, is to reduce and relieve itchiness. And ultraviolet light treatments, and last is the medications. The next chronic myeloproliferative disorder is the chronic myelogenous leukemia. It is a slow-growing cancer in which too many myoblasts are found in blood and bone marrow. The vast polycythemia is mainly RBC, while itong si chronic myelogenous leukemia, this is a mainly myoblast naman. The chronic myelogenous leukemia may get worse over time as the number of myoblasts increases in blood and bone marrow. The signs and symptoms of chronic myelogenous leukemia are these following. So the symptoms, first, meron kang fatigue, malaise, weight loss, yung pagbaba ng timbang, left upper quadrant pain or mass, the easy processing, bleeding, and fever. While if mga signs naman, you have a pallor, splenomegaly, yung enlargement of spleen, the lymphadenopathy, this is a swelling of lymph nodes, hepatomegaly, enlargement of liver, and purpura. Chronic myelogenous leukemia is usually marked by a chromosome change called the Philadelphia chromosomes, in which a piece of chromosome 9 and piece of chromosome 22 break off the trait places with each other. It usually occurs in adults and rarely lang sa children. Myelofibrosis is a progressive chronic disease in which bone marrow is replaced by a fibrous tissue and blood is made in organs such as liver and the spleen instead of bone marrow. Over time, this leads to progressive bone marrow failure. It is characterized by a rapid development of obliterative myelofibrosis. Under normal conditions, the bone marrow provides a fine network of fibers of which stem cells can divide and grow. Specialized cells in the bone marrow known as fibroblasts make these fibers fibrous. In primary myelofibrosis, a chemical released by high numbers of platelets and abnormal overstimulated the fibroblasts. In primary myelofibrosis, there are two phases, which is in a bone marrow and a peripheral blood. So in a bone marrow cellular phase, this is initial hypercellular with increase in maturing cells of all lineages. The megakaryocytes are large, dysplastic, and abnormal clustered, while in peripheral blood cellular phase, they have marked leukocytosis, which is increase in production of WBC. Third of erythrocytes characteristic. There are third of erythrocytes, which is dracocytes. And meron din siyang basophilia, which is increased production of basophils. In early stages, platelet be normal or elevated with large size platelets progressive disease. The clinical features of chronic myelogenous leukemia are these following. The median age of diagnosis is 60 years old. Weight loss, pagbaba ng timbang, bleeding, meron din siyang splenic pain, and meron din siyang jaundice. The another chronic myeloproliferative disorder is the essential thrombocythemia. So, essential or primary thrombocythemia, or ET, is a chronic myeloproliferative neoplasm, is the most common cause of thrombocytosis and is usually diagnosed by excluding all the causes of reactive thrombocytosis. It is characterized by peripheral blood platelet counts exceeding 1 million per UL and uncontrolled proliferation of marrow megakaryocytes. Although the platelets count may be markedly elevated in other myeloproliferative disorders, such as myelodysplastic syndromes, persistent marked elevation of platelet count is an absolute requirement for diagnosis of essential thrombocythemia. It is also a rare blood disorder in which your bone marrow makes many platelets. The clinical manifestation of essential thrombocythemia, meron siyang hemorrhage, meron din siyang platelet dysfunction, and thrombosis. The degree of thrombocytosis has not been found to reliably predict hemorrhagic or thrombotic events, and there is no specific clinical signs and symptoms of essential thrombocytopenia. The symptoms of essential thrombocythemia is you have a headache, masakit yung ulo, syncope, atypical chest pain, masakit yung dibdib natin, acral paresthesia, or this is the early symptoms of neuropathy, and erythromelalgia, a burning pain of hands or feet associated with erythema and warmth. One of the clinical manifestations of essential thrombocythemia is thrombosis. So thrombosis have two with the arterial and the venous. So the arterial is commonly involved are those in the legs, the coronary arteries, the renal arteries, but involvement of the mesenteric, subclavian, and carotid arteries is not uncommon. Neurologic complications are relatively common, wherein a venous thrombosis may involve the large veins of the legs and pelvis, hepatic veins, or splenic veins. So the primary cause of death of patients with essential thrombocythemia is associated with a combination of advanced age and high incidence of cardiovascular thrombosis. Another clinical manifestation of essential thrombocythemia is hemorrhage. So hemorrhage is occur less than thrombotic episode in patients with ET. The hemorrhagic manifestation of ET are mucocutaneous in nature with gastrointestinal tract bleeding occurring most often. The other sites of bleeding include the mucous membrane of the nose and mouth, the urinary tract, and the skin. Bleeding symptoms may be aggravated by aspirin use. Occasionally, a patient has a paradoxical combination of thromboembolic or the clotting and the hemorrhagic episodes in association with essential thrombocythemia. A patient with ET who has had a thrombotic event may have a hemorrhagic event later. The clinical lab findings. So platelet size is heterogeneous, and platelet may be notably clumped on blood films. Platelets may be agranular or hypogranular and have a clear light blue appearance on a routine white stain film of the peripheral blood. The presence of giant and bizarrely shaped platelet is characteristic of myeloproliferative disorder. The megakaryocyte fragments or nuclei are commonly encountered in peripheral blood. The number of volumes of megakaryocytes are increased in the bone marrow, and they are predominantly large, show some cellular atypia, and tend to form cluster. The platelet of some patients who have experienced thrombotic episodes with its clotting are associated with increased binding affinity for fibrinogen. These patients also have elevated levels of thromboxane B2 and beta thromboglobulin in the blood. These findings suggested enhanced in vivo platelet activation and possibly explanation for thrombotic tendencies of patients with ET. The bleeding manifestation may be related to variety of qualitative abnormalities in platelets, including the deficiencies of epinephrine receptor and ultrasound defect in the granules, mitochondria, and microfilaments. Often, the platelets are functionally defective when tested in vitro. Platelet aggregation is usually absent in response to epinephrine and may be decreased with adenosine diphosphate, but is usually normal with collagen. Lack of epinephrine response may help to differentiate uh, essential thrombocythemia from reactive thrombocytosis because this response is usually normal in reactive thrombocytosis but absent in most cases of ET. So the platelet adhesion will also be decreased. The The treatment of essential thrombocythemia is when treatment appears necessary secondary to thrombotic tendencies or splenomegaly, a variety of myelosuppressive agents. So, bibigyan ka ng myelosuppressive agent. Example, the melphalan and busulfan. Well, if inpatient with life-threatening hemorrhage or thrombosis and extremely high platelet count, the therapeutic platelet pheresis may be used or rapidly reduced only temporarily and elevated platelet count. So, if platelet pheresis, ito na yung gagamitin if life-threatening na yung hemorrhage or thrombosis of the platelet. And other one is the pegylated alpha interferon. Next is the anagrelide and the ruxolitinib or Jakafi. So that's the end of my report about the thrombocytosis associated with myeloproliferative disorder. Thank you po.